Good morning, ladies and gentlemen. Welcome to our first province-wide renal biopsy rounds for 2018. We're only going to be presenting 3 cases today. The 4th case, unfortunately, clinical data did not come in time, so I decided not to present it at this time. The first case will be presented by Alwyn. Up to you.
Thanks, Alex. So this is a case that was sent as a consult into my office last summer. JK was a 69-year-old man who I first saw on May 30th last year. He presented with mild to moderate peripheral leg edema, which was intermittent for almost a year. The severity had unchanged for approximately 9 months. He didn't have any rashes. He had no hematuria. He had mild shoulder, sorry for the spelling mistake, shoulder and knee arthralgia, but his mobility wasn't limited. He wasn't taking any over-the-counter medication or herbal medication. He never had a renal stone history. So this is all in a background of acute lymphoblastic leukemia. He had the Philadelphia chromosome positive, and this was diagnosed in August 2015. He was induced with hyper-CVAD, which is a combination of vincristine, prednisone, cyclophosphamide, and L-asparaginase, plus imatinib. The consolidation chemo then was cytarabine and methotrexate, and he had 5 cycles, and the dose was modified to 80% in each cycle because of his performance status tolerance profile. He had intensive therapy, and it was completed in January 2016. And then he was maintained on imatinib 600 milligrams daily, which is the standard dose. The complications post-chemo included S1, S2 varicella in 2016, and from then on he had prophylaxis with valacyclovir. He had a left lower lobe pneumonia in January 2017. He also had a background of ischemic heart disease. He had medically treated ischemic heart disease, which was stable and was asymptomatic. He also had a background of asthma and hypertension. There was nothing really relevant in his family history, social history. His family were all well, retired electrician, non-smoker. His medications included, as I mentioned, imatinib, 600 milligrams daily, as well as an ARB, amlodipine, valacyclovir, and rosuvastatin. On examination, when I saw him in May, his blood pressure was 135/65. He was fully mobile. He didn't have periorbital edema. He didn't have rashes. Joint examination was fine. He had a right-sided wheeze, but no evidence of pulmonary edema. He had pitting edema to the knee levels bilaterally with no skin breakdown. So when I saw him, he had a normal white cell count. He was a little anemic, but it was hypochromic microcytic, and he had normal platelets. His creatinine was 104, GFR 63. His albumin was 60. His cholesterol was normal. SPEP was normal. Urinalysis at 3+ protein, 2+ hemoglobin, Highland CAS, and ACR was 218. 24-hour protein was 3.3 grams, and he had a previous 24-hour collection done the previous November, which was 1 gram. He also had a CT of his abdo-pelvis as part of his staging, and he had normal kidneys size and echogenicity on that. His ANA was negative. So then he went on to a renal biopsy, which Alex is going to tell you about.
The renal biopsy was a good one, plenty of glomeruli, and in this, I guess in this field, you can see here's a glomerulus that doesn't look, it looks fairly good. Another one here, though, shows what appears to be some mesangiolisis, segmental mesangiolisis, and another glomerulus here, essentially normal appearing. Higher power view of one glomerulus shows congestion in some glomerular capillaries, as well as what appears to be some proteinaceous material in a quite widely dilated capillary loop. The tubules in this field here appear unremarkable. Another glomerulus shows again a segmental ballooning of glomerular capillary filled with proteinaceous material as well as red cells. The PAS demonstrates essentially glomeruli that a couple of glomeruli that appear unremarkable, the two top ones. There may be some increase in mesangial matrix, but otherwise not too bad looking. However, in this glomerulus, the lower glomerulus demonstrates essentially mesangiolysis in one segment. And you can see it here, breakdown of the mesangium. It doesn't stain very well with the PAS. And the capillary loop, there's no really well-defined capillary loop, which seems to be in the process of ballooning. Another glomerulus here demonstrates, this is a good demonstration of this mesangiolysis, the loss of the anchoring of the capillary loop, essentially the ballooning out of the capillary loop. And there is one obsolete glomerulus here. The silver stain, again, demonstrates the capillary microaneurysm, the loss of connection of the anchoring points of the capillary loop, the ballooning out of the capillary loop. And another glomerulus as well, showing the same change with some proteinaceous material as well as red cells in this capillary microaneurysm. The immunofluorescence was entirely negative, and on electron microscopy, you can see the glomerular basement membranes here, and there is this subendothelial widening and rarefaction, as well as sort of loosening of the mesangium here, and as well in here. Very typical of mesangiolysis and this lifting off of the endothelium. There are no electron-dense deposits. So these findings, in fact, are quite characteristic of a thrombotic microangiopathy that is essentially mostly glomerular, predominantly a glomerular target. And of the drugs that the patient is on, imatinib is a well-known, well-recognized culprit as a cause of thrombotic microangiopathy. I just thought I'd go through the classification of thrombotic microangiopathy, and this is the one proposed by the European Pediatric Research Group. And they divide these thrombotic microangiopathies into those with established etiologies versus those, as I'll show you in the next screen, of disease associations. In the established etiologies, of course, the first one that's very well known is an infection, Shiga toxin, and invasive strep pneumonia, giving you classical, especially the Shiga toxin, giving one the classical hemolytic uremic syndrome. Then there is the alternate pathway complement dysregulation, which is now a very hot topic for everybody, and this is both familial and acquired. Then you have the ADAM TS13 protease deficiency. Again, this is the one associated with a thrombotic thrombocytopenia purpura, which can be familial and acquired. Cobalamin or cobalamin deficiency is also a well-recognized, albeit rare, cause of thrombotic microangiopathy, and one drug that has been apparently definitely shown to be a cause of thrombotic microangiopathy is quinine. Among the etiologies or those associated with disease, at least thrombotic disease association, we have viral infection, HIV being one. Malignancy, we have, of course, the thrombotic episodes with, for instance, pancreatic carcinoma. Chemotherapy, radiomimetic drugs such as mitomycin C has been shown to be associated with the development of thrombotic microangiopathy. Radiation, hematopoietic stem cell transplantation. Certainly a number of drugs have been associated with thrombotic microangiopathy, including calcineurin inhibitors, antiplatelet drugs such as ticlodipine, clopidogrel, VEGF inhibitors, and others. And finally, of course, we have autoimmune disease such as antiphospholipid antibody syndrome, SLE and scleroderma, malignant hypertension, and pregnancy. All of these have been associated with thrombotic microangiopathies. And now I'm going to turn the floor back to Alwyn. Oh, first of all, I want to go through this. Among the drug-induced, the radiomimetics, calcineurin inhibitors, quinine, the antiplatelet drugs, VEGF inhibitors, and the tyrosine kinase inhibitors, imatinib and bosutinib.
So Alex has gone through some of this, but in relation to this case, the Philadelphia chromosome is characteristics cytogenetic abnormality only associated in 15 to 20 to 30% of adult ALL, as you're more familiar with it in CML. And it results in the formation of the BCR ABL oncogene, which is the target of these tyrosine kinase inhibitors. Imatinib, which is one of the oldest tyrosine kinase inhibitors, we all know it as Gleevec. It specifically inhibits proliferating myeloid cells containing this BCR ABL oncogene. And it also has an effect on platelet-derived growth factor receptor and c-KIT, which is upregulated in GIST tumours, but really minimally harmful in normal cells. Bosutinib, which is a newer version of tyrosine kinase, is supposed to have a narrower adverse effect profile, and its mechanism of action is very similar, but thought to have less side effects. And then the mechanism of the glomerular injury causing the proteinuria has been looked at a little bit in pediatrics, but again, it's not very clear. The inhibition of the vascular endothelial growth in the vascular growth factor expression in the podocytes by the tyrosine kinase inhibitors has been suggested as the pathogenesis, but there is a wide spectrum of proteinuria versus TMA in these cases. So to follow on the case then, so the hematologist, once we got the biopsy result back, switched the patient from anatinib to bosutinib at the end of June. And I put him on furosemide for his edema. He developed a respiratory tract infection in September, which is more associated with the bosutinib, and he did have underlying asthma. It was treated successfully. His edema actually reduced quite a lot between June and December when I saw him last, and he remains in remission. Now, it is thought that with somebody who has Philadelphia chromosome associated with ALL, that the addition of one of these tyrosine kinase inhibitors reduces the reduces the relapse rate in 3 years from 25% to 68%. So that's why they. Now, this is a very difficult site to see. It's just a snapshot of the blood work and urine tests during that time, where the arrow is, that was June 2017. So that's when the switchover happened between the imatinib and the bosutinib. You can see at that point, at the very bottom, the 24-hour urine protein was 3.3 grams. And then, actually, this shifted a little bit. It was December 2017, the 24-hour urine protein was 1.8 grams. So his edema had markedly improved, but you can see where there is a slight increase in his creatinine, which is kind of a third the way down the page. He had been getting quite a lot of problems with his chest, and also has been seeing the cardiologist as well for mild heart failure, which again is another side effect of these as well. So at this stage, I'm going to be seeing him in the next week or two. And the plan I'm putting a lot of pressure on the haematologist to get him off these tyrosine kinase inhibitors altogether. He'll be 2 years post finishing treatment at this stage. So I just want to see, are they happy to take him off it at this stage? Because I think there's still some activity going on in the kidney, and we may actually just biopsy him again to see what's happening. That's it. Anyone have any questions? Over to Alex again.
Thank you, Alwyn. If there are no questions, then we'll proceed to the next case. There we are. Nadia.
Thank you. So this is a now 60-year-old lady who is an organic blueberry farmer. And she initially presented in 2006 with what was ultimately diagnosed as antiphospholipid antibody syndrome. She presented with a right subclavian vein DVT. She was admitted to hospital, treated with local thrombolytics. And essentially her hematologic investigations were consistent with strong antiphospholipid antibody positivity. She had a more remote history of one miscarriage at 12 weeks and 2 normal pregnancies with C-section delivery, and then no other previous clots, no previous arterial thromboses. So she was initially treated with low molecular weight heparin. She was then switched to warfarin but developed severe headaches on warfarin, so she was unable to tolerate it. She was treated with low molecular weight heparin for 8 months and then switched to aspirin, low-dose aspirin from there on out. And her creatinine at that time when she presented was 63. She was then referred to a rheumatologist in 2013 because she had inflammation of her ankles. The rheumatologist saw her, did a dual energy CT, which actually was consistent with gout. She had findings consistent with her antiphospholipid antibody positivity, including livedo reticularis. On her labs, she had mild pancytopenia. She was strongly ANA positive, anti-double-stranded DNA positive, SSA positive, and had low complement levels. So the rheumatologist diagnosed her with SLE, with, quotes, minimal symptoms, started her on hydroxychloroquine, and she was started on uric acid lowering therapy for her gout and followed. She was then referred to me in 2014 because her creatinine was abnormal in the 100 to 110 range. It wasn't exactly clear between 2006 and 2014 when it started to become abnormal. On physical exam, essentially she has marked white coat hypertension. She's a very anxious lady, and did have some mild livedo reticularis on her labs. She had some microscopic hematuria with 4 to 10 RBCs per HPF on urinalysis. Her red cells were not dysmorphic. She had a low positive urine ACR at 5.5. She had a normal renal ultrasound. She had urologic investigations, which included a cystoscopy, which was normal. And in follow-up, she was reluctant to have any invasive investigations. So we followed her along for a while. Actually, her microscopic hematuria went away, and her urine ACR normalized, and her creatinine was stable. It didn't improve, but it was in the 100 to 110 range. So in August 2016, she fell off a ladder She ended up fracturing her pelvis and right radius. She was admitted to hospital. Her aspirin was held. She had surgery on her wrist. And following her surgery, she became, this was at RCH, so I don't have all the details, but she became quite confused, hypotensive. She had electrolyte disturbances, and she developed acute kidney injury with a creatinine that peaked at 191. She was diagnosed with adrenal insufficiency, and imaging showed bilateral adrenal hemorrhage. So she was assessed by hematology and rheumatology and the whole works, and it was unclear whether this could have been maybe a preceding thrombotic event followed by adrenal hemorrhage. She was actually recommended to switch from ASA to apixaban, but she declined. She has a lot of concerns about reversibility of the agent, and she just restarted her low-dose ASA. So following her hospital discharge, she never recovered to her previous baseline. Her creatinine was 120 as of October 2016. Her creatinine continued to worsen. It was 146 in February 2017. Her urinalysis all this time was persistently bland, and her urine ACR is normal. So she's recommended for renal biopsy, which she declined until her creatinine continued to rise up to 166 in October 2017. Hand it over.
Okay, this lady had a good renal biopsy again, and in this field here we have a number of glomeruli. The only really significant change is sort of a mild variable mesangial matrix expansion with some mild mesangial hypercellularity. There is some focal interstitial mononuclear cell infiltrates that you can see over here. Otherwise, the tubules don't look too bad. There are some chronically atrophic tubules, but in this field there are only a few of them. However, the arteries were another story. In this field here, we have an artery in which there is quite a bit of eosinophilic material within the wall and really within the endothelial, or at least subendothelial, in the intima. And there are a number of chronically atrophic tubules here, as well as down in this corner. The PAS demonstrates what appears to be some contraction of the glomerular tuft. In this glomerulus here, this glomerulus really shows only some mild variable mesangial hypercellularity. But what you do see here is PAS positive material within the wall of this small artery. And indeed, if you look at this arteriole here, there appears to be some myointimal proliferation and some stenosis of the lumen. This glomerulus shows a PAS positive, a large PAS positive deposit. Really, this is within the hilum or just in the afferent arteriole or efferent arteriole. And this, one might say, okay, it could be hyaline or it could be, in fact, a PAS positive, possibly an immune deposit in the wall of the arteriole. This H&D stained section shows an artery that has in fact been previously thrombosed, so it's got an organizing thrombus, which in fact has been recanalized. And this is a trichrome stain, again demonstrating an artery. This is the smooth muscle here. This is the essentially organized thrombus. This is a remainder of probably the original lumen, and then you have these slit-like, probably recanalized small little lumens forming. This is from a frozen section, and this shows actually what a strongly eosinophilic thrombus in an artery. It looks like a fresh thrombus. And on immunofluorescence, There was granular mesangial staining for IgG, C1q, and C3. And interestingly enough, there was quite strong focal vascular staining for IgG, IgM, C1q, and C3. And that artery, that small artery that I showed you previously on the frozen section, this is fibrin. So this is a fibrin thrombus within that artery. And on electron microscopy, as one would predict from the immunofluorescence, we had some scattered mesangial electron-dense deposits and some widening of the mesangium, but no deposits along the glomerular basement membranes. So the diagnosis in this case was a thrombotic microangiopathy, presumably secondary to antiphospholipid antibodies. And that was manifested by, as we saw, that thrombosis, fresh thrombus within an artery, as well as the recanalized organized thrombosis in one artery on histology. The patient also had, because of the deposits, these large deposits within some arterial walls, diagnosed as a lupus microangiopathy or a lupus vasculopathy. And finally, we have mesangial lupus glomerulonephritis and ISNRPS class 2, which was, I thought, quite unusual in that I usually associate lupus microangiopathy or vasculopathy with the more severe forms of lupus, namely class 3 and class 4. And obviously, the thrombotic microangiopathy, we have seen rarely, but we do see this in lupus, even without an antiphospholipid, with cardiolipin antibodies, which are probably similar to the antiphospholipid antibodies. Thought this allows me to sort of move into a topic of renal vascular lesions that we do see in lupus. And these are probably the uncomplicated vascular immune deposits, which are quite common. And we basically pick these up on immunofluorescence, and we don't really see them on histology, or in fact, we don't really see them very well on electron microscopy. Then you have the non-inflammatory necrotizing vasculopathy. This is also known as a lupus microangiopathy or a lupus vasculopathy. And this is when you see these large deposits in the intima media of vessels, of arteries. And this is also known as lupus microangiopathy, and as I mentioned before, this is usually seen in more severe forms of lupus nephritis. You can get thrombotic microangiopathy associated, at least in an association with lupus, not all that common. Small vessel vasculitis, quite rare, but this is the ANCA-vasculitis that we do see rarely on occasion associated with in patients who do have lupus. And finally, atherosclerosis, which in fact, intimal sclerosis, which is quite common. I just want in this slide to just to give the results, sort of simplify the results of a study done in 2013. It came out of China, Wu et al., and it was in Kidney International. And they looked at 341 biopsies in patients with lupus, and in 279 of the biopsies, there were one or more vascular lesions. The most common vascular lesion seen was the uncomplicated vascular immune deposits. Atherosclerosis was seen in about a quarter of the biopsies. Of interest, thrombotic microangiopathy was seen in 18% of the biopsies in their group. Non-inflammatory necrotizing vasculopathy was seen in 4% of the biopsies, and small vessel vasculitis, the rarest of all, was seen in 1%. Of interest is the finding that thrombotic microangiopathy was really associated with the poorest outcome in their group of patients. And in fact, when they did proportional hazards, a Cox analysis, They showed that only the thrombotic microangiopathy improved essentially the score. It's really improved not the results of the patient, but allowed one to made things a lot worse, significantly worse. Either the chronic forms of thrombotic microangiopathy and the acute forms. Okay. Caroline.
Okay. So by the time she had her biopsy done and came for follow-up, her creatinine had actually increased further slightly, up to 174. Assuming that most of her progressive renal dysfunction was related to the TMA rather than the lupus vasculopathy, she was started on apixaban 5 milligrams BID. Recall she had the previous severe reaction with headaches to warfarin. I did discuss the lupus vascular changes with Dr. Barber, and I could let him speak to them himself afterwards, but in essence, her lupus therapy hasn't changed. She's just on hydroxychloroquine, and it's unclear whether those vascular changes are impacting anything at this point, and with respect to her long-term prognosis, what effect it will have. But in any case, after a couple of months of anticoagulation, her creatinine has already improved down to 149 as of earlier this month. That's it.
Does anybody have any questions regarding this case?
Thanks, Alex. I have a quick question. So when I discussed this case with Nadia, my interpretation of the lupus vasculopathy is, as you mentioned, it's often associated with worse glomerular lesions, and our immunosuppression approach has been traditionally targeted just towards the glomerular lesions. This is a unique case because the APLA findings aside, which required anticoagulation, the glomerular lesion was only a class 2 lesion, which itself wouldn't usually require any treatment. And so I'm not aware of any benefit of treating lupus vasculopathy. I'm not sure if you're aware of anything, associated studies or anything out there that would suggest that we should consider it as a separate lesion when we're considering treatment. I usually acknowledge it, say it's probably associated with maybe a worse outcome, but treat the glomerular lesion.
Okay. I have very little personal experience with lupus microangiopathy or vasculopathy. I guess somewhere in my head it's been associated with worse outcomes. And I thought in the older studies there had been sort of a suggestion that lupus microangiopathy is associated with a worse outcome. The problem there is that it's usually seen with the most severe forms of lupus nephritis, so you've never been able to separate them out. This study by Wu, he looked at the effect of these vascular lesions on outcomes, and essentially using activity indices and the chronicity indices that were developed at the NIH, the only one that they could actually show had an effect was the thrombotic microangiopathy. In other words, basically an independent effect. If you added the chronic changes that you see in thrombotic microangiopathy to the chronicity index and therefore form a new type of chronicity that considers that, it was in fact the only significant factor that affected prognosis of all the various factors that these indices look at. So, but my own personal experience, I really don't know, because we see so little of it. We see a lot of cases with lupus where there are deposits on immunofluorescence, and you don't see them. You just don't see them histologically. Any other questions? None? Okay, so we will move to the last one. Nadia.
Okay, so the next case is Ms. S.A. She's a 23-year-old UBC student with a past medical history of congenital club radius, migraine headaches, and a baseline creatinine of 57 in 2015. She's on the oral contraceptive pill and is generally quite a healthy young woman. She had a swab-proven strep throat in September 2017, was treated with 10 days of penicillin and entirely improved. She then presented about a month later with a 1-week history of flu-like symptoms with nausea, vomiting, malaise, fevers, and chills. She was seen in the ER at Burnaby General Hospital. She didn't have any labs performed initially. She was discharged with a recommendation to take Gravol for nausea. Her symptoms became worse over the subsequent days with epigastric pain, loose stool, back pain. She noted decreased urine output and really couldn't tolerate anything orally. So she went back to the Burnaby General Hospital ER on October 15th. She was hypertensive at 180 over 105, and she was mildly confused. Her initial labs showed a hemoglobin of 48, platelet count of 43, marked schistocytes on the peripheral film. Her coags were normal. She had a creatinine of 956. Haptoglobin very low, elevated LDH, bilirubin, and AST. Other investigations that came back pretty quickly included a DAT, which was negative. She was beta HCG negative, ANA negative, and had low complement levels. So she was transferred to Vancouver General Hospital. And it was relatively quickly, I guess the provisional diagnosis from the beginning was atypical HUS with the obvious differential diagnoses. She started on a daily Plex and, of course, hemodialysis. So while she was on therapy, some of the other results that came back fairly quickly was that her virotoxin was negative. She's HIV negative. Antiphospholipid antibody testing was negative. Her ADAMTS13 activity was normal, and her CH50 activity was severely decreased at less than 1%. So she was then on plasma exchange basically daily for, by this point, probably 2 to 3 weeks. And applications were getting made for eculizumab, essentially. So because she wasn't improving on Plex, and because of the treatment that was likely to happen, she had a renal biopsy, I think mainly to make sure that there was nothing else going on renal-wise and for prognostic reasons, et cetera. I wasn't on at that time, but I think that's basically the short of it.
Okay, in this field, we see 2 glomeruli. The one on the lower, your lower left shows essentially ischemic contraction, whereas the other glomerulus just shows some an increase in mesangial matrix, and between them there is an arteriole demonstrating myointimal proliferation, onion skinning, and really quite marked stenosis of the lumen. The portion of artery here shows intimal sclerosis. Another field demonstrates a glomerulus that really shows, essentially was probably quite congested, but also shows some mesangial, really quite widespread mesangial, some mesangiolisis. And here you have another arteriole demonstrating myointimal proliferation and really quite significant or really very severe stenosis. In this field here, an arteriole essentially here is thrombosed. This arteriole shows essentially is dilated. It's massively congested with huge numbers of red cells in here, and probably is due to an obstruction or a thrombus further downstream. Here we have insudation of red cells into the thickened intima, and this is very characteristic of thrombotic microangiopathies. You can see here the somewhat atrophic tubules with reactive nuclei, really quite indicative of acute tubular injury. This is a PAS stain, and again, this is actually the same glomerulus that I just showed. And you can see the arteriole here is thrombosed. The glomerular tuft is contracted, showing marked ischemic change, and this is that very congested arteriole that we saw previously. The silver stain, again, we have this contracted glomerulus, this very congested arteriole. You can see the glomerular basement membranes are vastly contracted due to basically no blood flowing through acutely. You've also got ischemic change in this glomerulus as well as in this one here. And if these arterioles have basically, this is probably due to thrombus in there. This is a thrombosed arteriole with marked, at least intimal insudation by red cells. And again, we have this mucoid intimal thickening and stenosis, fragmentation of nuclei, quite characteristic of thrombotic microangiopathy. Here is a small artery showing the mucoid intimal change and marked stenosis of the artery. And again, mucoid intimal change, stenosis of the arterial lumen. An artery again, this marked intimal change. You've got acute tubular injury with tubular dilatation or ectasia, lining of the ectatic tubules by atrophic cells, and prominent nuclei, or at least the reactive nuclear change. Immunofluorescence, this is an arch, these are arteries, and it shows positive staining for IgM, C1q, C3, and fibrin. Characteristic, again, of thrombotic microangiopathy, and on electron microscopy, this glomerulus shows mesangiolisis, extensive mesangiolisis, and the subendothelial widening and rarefaction in here, as well as some endothelial cytoplasmic swelling. And these changes are really the changes of thrombotic microangiopathy, affecting predominantly the arteries and our small arteries and arterioles, and quite consistent with an atypical hemolytic uremic syndrome. The atypical hemolytic uremic syndrome, as everybody is aware of, is due to dysregulation of the alternate pathway of complement activation. And in this slide here, the genetic mutations that have been, demonstrated in atypical HUS, the most common are mutations affecting complement factor H. These mutations may be 80% sporadic and 20% are familial. We also have mutations in complement factor I, complement factor B. These have also been demonstrated. Membrane cofactor protein, thrombomodulin on rare occasion, hybrid gene formation resulting in dysregulation, then combined mutations, and deletion of the complement factor H-related protein 1. And you also have, of course, autoantibodies, especially to factor H, which can result in dysregulation of the alternate pathway. And back to Nadia.
Okay, so essentially she was plasma exchange dependent with no renal recovery, as I sort of alluded to earlier. Many of you probably heard of this case. It was pretty widely publicized on the CBC and other places. Her eculizumab application was approved, and she had her first dose on November 22nd. And she's actually doing well. Her kidneys started to improve. At the time I made these slides, her pre-dialysis creatinine was in the 200s. And in fact, I think she has been off dialysis for about 10 days or so now, probably coming to see me in the office soon. Last dialysis, January 11th. Thank you. In terms of the other testing that has come back, she does not have antibodies to complement factor H, and her genetic testing is still pending.
Anyways, the floor is open to questions. Any questions regarding this case or even any of the other cases? If not, do you have?
Just to add to the last part of Nadia's slide, my understanding from Paul Jensen actually is the complement factor H levels were low. And so the genetic testing results aren't back, but this could be consistent with a complement factor H mutation, which would put her at a pretty high risk of every problem that we're going to have to deal with down the road, such as recurrence post-transplant, such as continuing using the drug indefinitely versus being able to come off or not.
Okay, thanks. If there are no other questions, this session is adjourned. Thank you. That's it. Fridays, though, I don't work on Fridays, but I used to work on Fridays, so I know we did St. Paul's. So I did at St. Paul's, but I have other colleagues that are going to present these rounds, and they work at St. Paul's. So that's probably this is the only time. Well, it was last in December we presented rounds.
The one with different.
Yeah, from Seattle.
Yeah.
Well. Okay.
Thank you. Your call will be disconnected.